Management of patients with asthma and chronic rhinosinusitis with nasal polyps has been transformed over the last few years. We now know so much more about the diseases and their pathology. We can chart the diseases using biomarkers, and biologics have transformed care. But with these breakthroughs, education of physicians and patients becomes ever more important. Countering disinformation or myths is paramount to achieve optimal patient care. So today's show is all about myth busting. Is it fact or fiction? Hello and welcome to EUFOREA News. I'm Dr. David Bull. Ever since the discovery of the inflammatory nature of asthma and chronic rhinosinusitis decades ago, these two conditions have been arbitrarily split up into lower airways disease, taken care of by pulmonologists, and upper airways disease taken care of by ENT specialists. In addition, allergologists focus mainly on the allergic trigger of inflammation in both upper and lower airways inflammation. However, with new options of care targeting inflammation and the inflammatory process coming online, it is now time to revolutionise care to ensure there are common approaches when targeting the disease in both the upper and the lower airways simultaneously. So today we shed some light on breaking truths and on the unfortunate myths surrounding the care of patients with asthma and CRSwNP. Well, to help me navigate this minefield, I'm delighted to be joined by two eminent specialists. Firstly, Dr Marjolein Cornet. She is a consultant otorhinolaryngologist at Urine Hospital in Amsterdam in the Netherlands. She's also a EUFOREA CRS and EPOS expert panel member. And joining her is Professor Enrico Heffler. He is Associate Professor in Internal Medicine and Head of Personalised Medicine in the Asthma and Allergy Unit at Humanitas University in Milan, in Italy. He's also a EUFOREA asthma expert panel member. Really good to see both of you. Thank you so much for joining me. Let's start then getting myth busting. If I can come to you first of all, Dr. Cornet, let's start with myth number one. I have a whole list here. Myth number one, CRSwNP and asthma are separate conditions. True or false?
Well, that's absolutely false, in my opinion. So what we see is that there is a large overlap of symptoms between the upper and the lower airways. And that's also why we call them the united airways. And it's not only that they have similar symptoms and they can influence each other, but they also have very similar patterns of inflammation. And we also know that most of the time, if you treat one of them, you can also achieve improvement in the other. So, for example, we know that in patients with CRS, up to 50% of the patients also has asthma. And it's also the other way around. Patients with severe asthma have around 40 to 60% chance of having CRS with nasal polyps as well. And that means that it's very important to work in a multidisciplinary team, so you can work together and achieve good results by working together for the whole united airways. So you need to ask for symptoms in the other field as well. So not only focus on the nose, but also ask questions about the lungs. And for the pulmonologist, the same. Not only ask questions about the lungs, but sometimes also ask about the nose and ask, for example, about the smell.
Fantastic. That couldn't be clearer. Right, let's move on to myth two. I'm going to stay with you, if I may, Dr. Cornet. Once nasal polyps are actually removed, they come back. Is that true or false? So what I'm really asking is, once you remove them, does that lead to a cure?
No, so that's something that we try to explain to your patients before surgery as well. So the reason of removing polyps is opening the airway up, cleaning your sinuses and making it more easy for the corticosteroids to reach the mucosa, which is diseased. However, it's not that you really cure the disease by removing the polyps. And we know that most of the time, the polyps will come back. And in about 60 to 80% of the patients, in the end, over 1 or 2 or 3 years, the polyps are there. So it's a chronic disease, and you need to explain it to your patients as well, that you need to have a chronic treatment as well.
Okay, I'll stay with you for one more question. So the third myth is about biologics. I talk a lot about biologics. So biologics are a threat to the ENT community because levels of sinus surgery will decrease, i.e. biologics are going to put you out of a job.
Well, that's actually something that we hear a lot. And especially in the beginning when the biologics came onto the market, this was the biggest fear of most ENT surgeons, because we all really would like to do surgery. So everyone was very scared that we lose a part of our job which we really like. However, while the biologics came on the market, actually we saw that there was a big difference in how we were treating patients. The only big difference which was there, that we had actually after doing a first surgery, when we have a recurrence of polyps, we could offer our patients a better treatment. And patients were very, very happy by being able to having the chance to be treated with a biologic. So actually in daily practice, it makes our job much nicer because we have happier patients, which also means that the doctor will be more happy. And also surgery still has a role in the treatment of CRS with nasal polyps. So there's also a big group of patients who do have a good reaction to surgery, which is very important to know. The only thing for the future, which is very important, is to better select these patients who will do good on surgery and who won't. Because if we can select the patients who will do good on surgery, we still can do surgery quickly. And maybe in the future, in other patients, we will skip doing surgery and go straight into treatment with biologics. And there's also the last possibility, and that's combining the both. And we need to do more research about how we can combine them and also about the positioning and timing of biologics. So that's a very interesting area.
Fantastic, thank you. Just very, very quickly, and probably it's a very easy answer for you. Myth 4, all patients take their medication exactly as prescribed. I think I know the answer to that.
Well, I think we know that patients do not. I think there's research which shows that about 70% of the patients do not do what you ask them to do. And hopefully they're honest about that, but I know they are not. So we really try to teach them about the chronicity of the disease. And if they understand better, I also have the feeling that they will use their medication in a better way. So I think education is very important for these patients.
Fantastic, thank you. Let me bring you in now, Professor Heffler, if I may. I'm going to ask you the same question. In your experience, do patients take their medication exactly as prescribed in your clinic?
No, unfortunately not. I mean, I totally agree with my colleague. A large proportion, up to 60-70% of patients, even when treating both upper and lower airways, actually they do not take appropriately. With an appropriate, let's say, way the drugs we prescribed. But that's actually also somehow reasonable for some patients, particularly for the most severe ones, for which, for example, the standard of care treatment, such as intranasal corticosteroids, for example, for chronic rhinosinusitis with nasal polyps, well, sometimes, very often actually, are ineffective to totally control the symptoms. So they stop using this drug also because they are less effective. While when we have very effective treatment, such as, for example, biologics, well, the adherence is absolutely higher. The adherence to treatment is absolutely higher, almost 100%.
Okay, let's move on to myth number 5. And this myth says that biologics are the last line treatment options after all else fails. I wonder if you just want to talk about GINA and EPOS and EUFOREA and what those guidelines actually say in terms of starting biologics.
Well, actually, so far, the biologics, actually, it's true that they are positioned as the last opportunity, last treatment, for example, for the GINA guidelines at step 5, and for The nasal polyposis side actually is slightly bit different, but anyway, the consensus, international consensus, is that patients should have been already treated by surgery before and constantly treated with intranasal corticosteroids. And when they are relapsing and having a potential new indication of surgery, well, that's the moment in which you can also consider to treat patients with biologics. So in reality, it is true that biologics are positioned so far as the last, not the very last result, but anyway at the end of the spectrum of potential treatments. But however, there is an increasing evidence, absolutely consistent from both upper and lower airways, that treating earlier is giving the best results. So there is a huge interest in achieving clinical remission, and clinical remission is achieved as soon as you start an effective treatment, in this case, a biologic. So the next challenge, the current challenge actually, is identifying the patients earlier as potential eligible for biologics, and therefore starting biologic as early as possible.
And let me just bring in Dr. Cornet at this point. Do you have anything to add on the points that Professor Heffler just made there?
Yeah, I totally agree what he was mentioning. So we know from research which has been done by Professor Hopkins that the sooner you do sinus surgery, the better the results are. So that's really the same in another way. So if patients have disease, you should take it seriously and treat them. And then hopefully in the future, we can do a better selection of these patients. And then like the next step would be biologicals in our current protocols. But maybe in the future that will differ as well. But quick treatment is very important and gives better outcomes.
Let's go back to you, Professor Heffler, if I may. I've heard this myth a great deal. So some people are saying, well, with regards to biologics, if a patient doesn't respond in a few weeks, say like 1 to 2 months, then the biologic has failed in asthma. True or false?
It's false. It's false because actually, well, despite the fact we have some biologics that are very rapidly actively, so for some biologics we can see some signal which is very rapid in few weeks, but despite that, actually, it is recommendable to wait for at least 6 months before giving a real judgment on the efficacy or not of the drug, because actually some drugs biologically are slower in achieving the results, and in general there is a large variability among patients in the rapidity of the effect. So and moreover, specifically for asthma, the outcomes we are evaluating are actually outcomes that takes time to be evaluated, such as, for example, the number of exacerbations. Of course, if you consider these in a few weeks, you will not have time to see the reduction. You need to monitor the patient under treatment for a longer period. Many recommendations say at least 6 months, and then trying to decide if there is an effect or not, and therefore deciding if keeping or not the treatment.
Thank you very much indeed. Let's come back to you, Dr. Cornet. What about the use of them in CRSwNP and this idea that if the biologic doesn't work in, say, 1 to 2 months, then it's failed? What's your view on that?
Yeah, so I agree with Professor Heffler that we see a big difference between the different biologics. So we know, for example, that in patients with dupilumab, we see like a stronger and earlier improvement of symptoms. For example, if you compare it with mepolizumab. And we know that, for example, in anti-IL-5, it takes longer to see these results, but the results finally will be there. So that's why our protocol also says that you need to analyze after 6 months and then make the decision to continue or stop the medication. So we have the same protocols for CRS as well as asthma.
And just very quickly, I'll stay with you here for our 7th myth. Inflammation only matters during exacerbations.
It's not, no, because we're talking about chronic inflammation. And chronic inflammation is something which is always there. So your immune system is reacting in ways it shouldn't react. So it's like always turned on and always working. So especially if I look in my field of work in rhinology, we don't really have sinusitis. We have chronic problems, chronic anosmia, chronic rhinorrhea, but not really exacerbations. We don't see them in the upper airways. And I think that's also different if you look to the lower airways.
Let's come to you then, Professor Heffler, on that note. And I just want to ask about lower airways disease and asthma. Our 8th myth is that clinical remission in asthma is a research concept only. Is that false? Should we be achieving remission in all asthma patients?
I think it is a false myth, actually, because clinical remission concept actually is a very clinical, as it says, concept, much more than a research one, because it is, well, when we talk about clinical remission, we talk the achieving more outcomes, not one single outcome, but more outcomes at the same time for a prolonged time or period. Well, this is exactly what we must do, we must obtain with our patients, because our patients deserve this kind of huge, big composite outcome. I really believe that in so far, biologics for both upper and lower airways, so for both chronic rhinosinusitis with nasal polyps and asthma, proved their efficacy greatly by evaluating one single endpoint at each for single study, and therefore that's the why we evaluated so far also in real life single outcomes, while actually having the opportunity to achieve an entire, a much more holistic, let's say, improvement, a super response somehow. So in achieving a multidimensional response, which is exactly clinical remission, it's something that is achievable in our patients, and it is actually the aim of also, I think, of the new drugs that will arrive in the market.
And let's just stay with you for our final myth. This is myth number 9. Short bursts of oral corticosteroids are harmless. Is that true or false?
Absolutely false. Absolutely false. There is clear evidence that even 2 short courses per year are able to predispose the patients to severe potential side effects related to corticosteroids. In particular, there is evidence that at least 2 short courses are able to predispose patients to have osteoporosis, bone fractures, infections in the subsequent year. So the use of systemic corticosteroids in a era in which we have better options such as biologics should be avoided. So I really believe that our aim will be to totally remove the use of systemic corticosteroids for our patients.
And Dr. Cornet, anything to add?
No, I totally agree. We used to give corticosteroids, do surgery, corticosteroids, do surgery, and that all over again. And we're very, very pleased that we have different options now. So we don't want to give corticosteroids anymore if it's not needed, because we can see the side effects. And it took us a long time to see how severe these side effects can be. So I think it's very, very good for the patients that we are one step further.
Well, I just want to say a very big thank you to both of you. You've been absolutely brilliant at myth busting, so thank you to both of you.
Thank you very much. It's great being here.
Thank you.
There you are, myth busting at its best. I hope you found that informative and educational, and above all, I hope it changes your clinical practice. Thank you so much to my guests, to Dr Marjolein Cornet, and also to Professor Enrico Heffler. Well, you can find more information about EUFOREA and also register for the EUFOREA educational events on the euforea.org website, where you can also sign up to receive the latest news via email. We're also on social media as well, on YouTube, X, LinkedIn, Spotify, Instagram and Facebook. Please do follow us. Until next time, goodbye.